Hi, I'm Dr. Michael Steinberg, Medical Director of Cardiothoracic Surgery here at Memorial Hospital in South Bend.
Hi, I'm Shakir Aslam, one of the interventional cardiologists with Memorial Advanced Cardiovascular Institute. The Memorial has taken this initiative, which started about the end of last year. Over the past 5 to 10 years, the treatment of valvular heart disease has really changed, and there are a lot of new innovations and a lot of different treatment options. So sometimes, when the patient comes to a cardiologist or to a primary care physician, they only have information from one side. So we have started this initiative where the patient can come in and see a cardiac surgeon and a cardiologist at the same time and get all the information before making any final decisions.
Yeah, and the heart valve concept is rather new, but it's been implemented at a lot of large teaching hospitals around the country. As Dr. Aslam was saying, the different modalities that are available to treat valvular disease have really expanded in the last 5 to 10 years, and therefore there's more and more complicated patients that are coming to see us, multiple valve problems, multiple options including repair, replacement, medical treatment, minimally invasive approaches, and now even percutaneous approaches to aortic valvular disease. So there's a whole host of options available to patients, and the decision-making process as we navigate through that can be complicated. And I think as professionals we've decided that probably the best way to provide the most up-to-date care to Michiana patients is to have a multidisciplinary approach where you have cardiology specialists and cardiovascular surgeons together in one room that look at echoes, look at CAT scans, and look at heart catheterizations and see the patient together to come up with a unified approach to give them the best care possible.
I think one of the things that patients receive, that they have individualized care. I think one treatment doesn't fit all. So some of the patients may need medication only. Some of the patients may be, optimal for open heart surgery. Some of them may be optimal for minimal invasive surgery. So when we discuss these cases in the valve clinic, we can individualize the treatment, and then we also have the coordinator who works with us in the clinic, and that person can follow up with the patient all the way along and guide them through different steps of the treatment, so that some of the tests can be done at an appropriate time, and patients, if they have any questions, they have one person to call to and ask all those questions rather than trying to get some information from other sources.
Yeah, Shaquille, I can't emphasize enough that point about having an individualized patient coordinator. I've had a lot of feedback from patients. They found that really helpful because a lot of patients are older. These are complicated decisions and a lot of testing is required. And to be able to have kind of one-stop shopping and one person to go to that guides them through this whole process from beginning to end is really helpful and comforting to patients. And I think it's really a great benefit for patients.
I think, as I said, over the last few years, a lot of things have changed. The criteria for surgery, criteria for medications, they have all changed. In the past, sometimes we waited too long for the patient to come to the operating room, before we did anything for them. But then it may be too late. They have developed left ventricular hypertrophy. They have developed left ventricular enlargement. Now we have fixed their valve, but they're left with all this dysfunctional heart for the rest of their life. So I think it's very appropriate to. One of the reasons patients should come to valve clinics so they can be followed along, so they can be treated at the exact time when it's needed to be treated, because as we know, some of these patients may be completely asymptomatic with severe valve disease, so we may have to treat them and do some other testing to find out if they have some symptom which they're not telling us, or do some kind of additional testing to find out whether the severity of the valve disease is severe enough that we should treat them before they develop any significant symptoms.
Yeah, and to reiterate that point, heart valve disease is not a one-stop fix. This is a lifelong problem, and some people need to be followed long-term. And so we don't just see a patient one time and then send them on their way. This is something that requires ongoing counseling, ongoing medical management, regardless of whether they ever have any sort of surgical intervention done. And in fact, probably, I bet half the patients that we've seen thus far in the valve clinic have been managed without any surgical intervention at all. And so it's I think, a huge bonus for primary care physicians to have a valve clinic in place that can follow these patients long term and really optimize their heart failure management as their heart changes over the course of the years.
Yeah, I think I should also emphasize, Mike, like some of the recent trials, like Partner 2 trial and Partner 1 trial, they've shown us that some of the older patients that in the past we thought they're high risk to do any kind of surgery. And in that trial, we've seen even those older patients, they have much less risk of surgery with some of the latest technology that we have, and they did much better than patients who didn't get any treatment or didn't get any surgery. And so that might be one of the reasons to send some of those patients to the clinic, because you may think that these patients are too old and they may not need any surgery, but we might be able to evaluate them and offer them some kind of treatment, which obviously will improve their quality of life and make them live longer.
Absolutely.
Yeah, this definitely is, the more regional effort rather than Memorial or, any of the other hospital clinic. This clinic is open to all the cardiologists from all different groups in the town, all the surgeons throughout all the different, health systems. And this is all about the patients, it's all about the benefit of the community. It's not about me or Mike or, Memorial Health System. It is just for the benefit of the whole community. So all the physicians and cardiologists, they are welcome. If you come to see us, that doesn't mean if you're already seeing a cardiologist or a cardiac surgeon, you have to change your cardiologist, change your physician. Those cardiologists, they can also come to the clinic and see the patient with the surgeon at the same time. So again, it's not really trying to change the physicians. It's a community-wide effort for the improvement of community patient health.
Yeah, I think that's something that we as physicians all have to get used to, and that's part of the changing landscape of medicine, is that the days of individual cordoned off care, I think, is coming to an end, and that in all of specialties, especially in complicated areas like cardiac valvular disease, it's pretty clear that having multiple specialties involved simultaneously yields the best outcomes and provides the best service for the patient. And so I think as providers, we have to come together and put aside practice differences, geographic differences, and do what's best for the patients. And so that's really what this is all about, is really trying to provide a unified approach to patient care. And it's a paradigm shift, and it's something that everybody has to get used to. And as Shaquille said, this is not about Memorial, this is not about myself or him, this is about all of us coming together to do what's best for our patients here in Michiana.
Yeah. I think I should also mention that, as was alluded earlier, that the treatment of valvular heart disease has changed over the last many years. In the past, we always waited till the patient develops symptoms, but sometimes that may be a little bit too late. So, we're really trying to catch the patient at the early stage, which is most optimal for their treatment. And a lot of patients with valvular heart disease can be completely asymptomatic, and they don't get discovered until they go on to having some other kind of surgery or some other kind of treatment, and they do some testing and they find out they have heart problem, which has been going on for many years and has not been taken care of, and that sometimes it may be too late to treat them. And we have seen that, in the past, that patients have been completely asymptomatic and they've been just cutting down their activity. They feel that's normal. As they're getting older, they're getting tired, they're getting short of breath. So instead of seeking more, evaluation, they try to cut back to their activity, and they feel it's just normal, but it's not really their age or something else. It may be the heart disease or something else causing them to slow down. And when we do the testing, we find out that they have significant other problems. And we also have seen in the past, some of the patients who have congenital valve disease, like bicuspid aortic stenosis, or bicuspid aortic valve, or moderate severe aortic stenosis, and they get followed up over a long period of time. And by the time they get to see a cardiologist or a surgeon, they already have developed significant left ventricular hypertrophy, and now they're left with dysfunctional heart, something that could have been treated early on and could have been prevented that way. Mike, do you have any thoughts about that?
I totally agree. I think one of the things that's changed here in the last 5 to 10 years is we've increasingly shifted to the left in the natural history curve, the point at which we intervene for valvular disease. And the old days, and by that I mean the 80s and the 90s, those results are skewed because we as surgeons and as cardiologists and as primary care doctors all waited too long to intervene. And it's clear that the sooner that you can intervene in a patient's natural history, their outcomes, both short-term and long-term, will be far improved. So for sure, we want to catch people before they have irreversible changes to their heart that leads to detrimental function. But we're also here for long-term care of patients that may just need to be managed medically. And so I think we really want to try and take care and assume the responsibility for the care of the whole spectrum of valvular disease patients. And so please use us, don't hesitate to call us, and we'll be happy to take care of and follow all of your valvular patients for as long as need be.
I should also, Mike, add to this, as we know, there are a lot of different treatment options now. So sometimes patients, look it up on the internet and they go to, out-of-town hospitals thinking that they're going to get some certain kind of treatment, and then they go up there and they get the same treatment that, is standard of care. And so something that they can get at home rather than going out of town. And, some of those patients, if we evaluate them and we feel that they will need, they'll benefit from minimal invasive surgery or percutaneous treatment or some of the newer treatment, we can guide them in the right direction. We're not going to ever, misguide them and not offer some of those newer treatments, even if we may not be able to offer those, locally at this hospital. And I think one of the other things that we should emphasize that when the patient is seen on an elective basis and all these surgeries are planned ahead of time, there are a lot of other treatment that we can do ahead of time so their perioperative course is better and they don't get some of the post-operative complications that will happen if they get these kind of surgeries on an emergent basis. Mm-hmm. And as Mike said, some of these patients, they may not need treatment, surgeries right away. They may need just medication. So somebody who has, for example, severe mitral regurgitation and they're asymptomatic, we may be able to start them on some of the medication and prevent their worsening of the heart failure over a long period of time. So somebody who might need surgery in 5 years, with some of those medications, we might be able to delay that up to 10 years or even longer. Treat their risk factors, treat their, hypertension, high cholesterol, smoking, weight loss, and some of those other activities. And that certainly does prevent the progression of the valve disease. And they may never need treatment for those valves if we do some of those interventions as well. And also Memorial Heart Valve Clinic has those options available, and we can guide them to the right sources. We can give them education. We can, answer the question that they might have. So I think some of those options are also unique to the valve clinic and to this multidisciplinary approach rather than, when they go see, somebody outside the clinic.